Well, good morning. My name is Maureen. I'm a nurse practitioner here at St. Luke's and your moderator for today's Friday Chalk Talk. I'm here to introduce Peter. He is our pharmacy clinical specialist in oncology with Advocate Aurora. He has worked in oncology for over 10 years and has seen firsthand the explosion of immunotherapy drug use for cancer patients. So Peter, if you want to take it away.
All right, thanks, Maureen. So thanks everyone for joining today. Couple of things about my presentation today. You'll notice that I'll have lots of photos of smiling people. I recently read a short article that stated that presentations that had people in general in them that you could tie into the presentation were remembered better and better recalled. So we'll see, right? But you'll notice that over and over. And what I'll try to do is I'll try to incorporate those people into the story of the presentation as we go along. I also want to disclose that I have nothing, no bias or anything to disclose about this particular subject. However, I want to state that there is quite a bit of literature out there on this particular topic, and I definitely did not encompass every literature piece that is out there, I'm sure. And this is a continually evolving topic as well. I'm sure there will be more literature over the coming years as immunotherapy drugs for cancer treatment are the #1 drug we use these days. So I believe we will definitely see more and more on this particular topic as well. So what is presented here today may not be the answer next year. So just wanted to go with that. All right, so let's pretend this group healthcare team is the part of that team taking care of a patient who's coming in for pain, but they're on an immunotherapy, and I'll represent her case in just a little bit. So some objectives for today. I want you to be able to list some key points that are in the current literature explaining the controversy between steroid treatment and immunotherapy. And I also want you to decide and develop your own plan about patients when you're done, taking into account some of the things discussed today and applying it to your particular patient situation. One abbreviation I do want to mention I will use here is IMEA, stands for immune-mediated adverse effect. And I'll get into that in just a little bit. Couple of things we won't be going over today. Immune-mediated adverse effect treatments with corticosteroids. This is the primary frontline treatment for patients having immune-mediated adverse effects from immunotherapy is steroid treatment. These are adverse effects that happen because of the ramping up of the immune system that these particular agents cause. I will briefly talk about some literature that looked at steroid use for these later on. But in general, we're going to focus on steroid use for other indications. Generally, I'll call those palliative symptoms today, just for the purpose of this topic. Also, we do use steroids very commonly with patients on immunotherapy and combination chemotherapy regimens. What you'll see there is just standard dexamethasone primarily given before the treatment and then perhaps for a couple days after. This is also standard of care and considered not controversial in the oncology realm. So we won't be discussing steroid use for prevention of chemo-induced nausea and vomiting either. So why is there an issue with using corticosteroids on patients on immunotherapy treatment? Well, theoretically, there is possible suppression of that particular treatment. These immunotherapy agents work by ramping up T cells to attack the cancer, shutting off checkpoints that the cancer used to evade T cells. But the steroids suppress T cells in general. And I'm very much giving a very generalization here, not going into details, but they suppress T cells as well as suppress antigen cell presenting activity, such as dendritic cells, which then ramp up the T cell response as well. So by suppressing these things, theoretically, they could possibly knock down the way the drugs work to kill the cancer, thus making the treatment not work and the cancer progress. Because of this, since the very beginning of these drugs being used, basically any trial has excluded any patients who have been on prednisone greater than 10 milligrams daily, or the equivalent dosing of another steroid. So all of those patients in prospective clinical trials have just been thrown out from the beginning. So what you'll see today is that we really don't see prospective clinical trials looking at steroid use for palliative symptom treatment. I will mention a couple that did look at immune-mediated adverse effect treatment, but again, nothing really out there prospectively looking at steroid treatment for palliative symptoms in this patient group. All right, so now our case. Let's say this lovely lady here is JG, 83-year-old female, and there's her nurse who's taking care of her right now as she's admitted to the hospital. And she has stage 4 non-small cell lung cancer. We know she has bone metastasis in her pelvis already, and this was irradiated before treatment with pembrolizumab was started. And it's been going on for the last 2 months. So she's received 3 doses so far. Now she's in with severe pain in her pelvis, and the medical team determines that this is likely due to metastatic disease at this time. Right now, from home, she's on oxycodone 5 milligrams every 3 hours as needed for her pain, and she takes about 4 of those a day. And a recent CT scan showed that she had a mixed response so far to the pembrolizumab treatment. The primary tumor in her lung has shrunk significantly. She's had other bone metastases shrinking. The metastases in her liver has also shrunk a bunch, but there is a spot in her pelvis that has gotten worse. This is a very common type of response that you'll see with immunotherapy, where certain lesions will get much smaller, but others may grow initially and then possibly shrink after a while. So the standard is to keep the patients then and want to continue the immunotherapy until you see if those lesions that didn't respond initially might respond later. So should we use steroids in this patient? Will it impact that immunotherapy treating the metastases as well? Is this a situation where we would want to use dexamethasone? And that's what I hope to discuss with the rest of today, and then hopefully discuss as a group for the rest of the presentation here. So here's the literature I could find. Again, full disclosure, this probably is not all of the literature that's out there, but here's some of the highlights. The first 2 on this chart are prospective, looking at, again, steroids used for immune-mediated adverse effects. And actually in larger trials and things, they've really found that, now here we had mixed results. The first one said no impact on overall response rate using it for immune-mediated adverse effects. Well, the second one said that, well, there's actually increased disease recurrence, and we had more issues in those patients who used it for that. So mixed results at first here on the prospective trials. Now, the next 3 are retrospective trials looking at steroid use, early on in treatment of these patients for these diseases. They're all in non-small cell lung cancer and all with different immunotherapy agents. And what they all found is that the steroid use, the patients who had steroids early on in treatment, usually it was in the first month or so of treatment, had decreased overall response rate, progression-free survival, overall survival, or discontinuation of the immunotherapy. However, when they looked at the indications for why the steroids were used, again, they weren't used for immune-mediated adverse effects. Immune-mediated adverse effects tend to occur at the 6-week mark or later, except for rash rash could possibly show up earlier, but usually it's after that's the first month that you would see any immune-mediated adverse effects. They rarely happen very early on. So these were all used for palliative indications. These were patients with brain mets already. They were having respiratory disease, severe dyspnea, fatigue needing stimulation. So these were patients who were basically sicker. They had worse disease. So the conclusions of some of these articles were like, well, it probably isn't the steroid necessarily that's suppressing the drug. It's the fact that these patients were just further along in their disease and were at a less likely chance of them responding in the first place. And that was the general, they found no evidence that the immune suppressive effects of the steroids impacted the immunotherapy. What they did find is that patients with worse disease tended to not respond as well. So that's what these particular ones found as a conclusion. A couple more I want to bring up. Again, 2 more in non-small cell lung cancer that were retrospective. The second one there looked at the Giglio, looked at the first 8 weeks of treatment, while the first one here looked at they were on steroids within the first day of treatment. So a little different than the first month of those other ones. But they found very much the same things. Those that were using it for cancer palliation had worse outcomes. Again, it's the reason behind, though, that they concluded that was probably why they were using the steroids in the first place and why they didn't necessarily respond. They really didn't feel like the steroids themselves were exerting any immunosuppressive effect that impacted the drug. Then we have a systemic review and meta-analysis that looked at 16 different studies looking at steroids and immunotherapy. And over all of these 16 studies, overall survival was worse in the steroid patients. But then they split up and looked at the rationale behind treatment. So these studies gave steroids at any point during treatment. And again, any steroids in all of these studies were defined as greater than 10 milligram prednisone equivalent daily. I'll note that as well. These weren't little bursts or anything. These were patients who were on it for more extended periods in general. They excluded patients who were on, like, let's give them 4 milligrams of dexamethasone for 4 days quick. They didn't include those patients because it's not considered immunosuppressive at that point. So again, really what led to that finding of overall survival being worse were those palliative patients with brain mets and other things. When they looked at the use for immune-mediated adverse effects, those patients had no difference in the patients who didn't receive steroids. So it's generally considered appropriate and not something that's going to worsen disease if you treat immune-mediated adverse effects with steroids. That is generally considered not a concern. Still is a little questionable on the use for palliative symptom relief. However, again, the conclusions of all of the studies I found generally said that these patients just have worse disease and are just unlikely to respond, really. So that's what I've summarized here at the bottom. Also wanted to mention very briefly, they have looked at steroid use in autoimmune diseases in patients on these drugs. This was another group that was completely excluded from any prospective trial with these agents. Again, because the thought of ramping up T cells would then increase disease flares. And there's really been a conflicting literature there. Some will say that the disease flares don't get worsened and steroid use isn't increased. Others will say that yes, disease flares do increase and there's elevated steroids, which then lead to worsening cancer outcomes. So it's kind of mixed there. kind of unknown at this point, the impact in those with autoimmune diseases. What I see in practice is a lot of these patients don't really have many other options for their cancer treatment. So they go ahead with it. And then if a disease flare pops up, they treat it. All right, so starting discussion today. I want to ask, what should we do in a situation such as JG's? I know I didn't give all the details, but just general patient like this, try to think of what would you do for a patient in this sort of situation where we definitely want to continue that pembrolizumab, but we have an indication where, a burst of steroids might really help the patient right now. So open it up. Please type in the chat if you don't want to unmute, and let us know what you think.
I'm sort of a novice at any of this, steroids and as far as symptom management, but I think I would give the short burst of steroids, the 4 milligrams, and see if it helps, like for 4 days, like you were saying. Also, maybe see if radiation is a possibility.
Yeah, they were irradiated already prior to treatment, but yeah, definitely. If you send them to radiation oncology, they might say yes.
Right.
One of the things that some of the medical oncologists have told me over the years is one of the things they need to be careful of is not sending somebody to radiation too often, because they tend to radiate.
Marty, you have your hand up?
Yeah, I was going to say, one of the things I would recommend is calling the oncologist and seeing if they have a strong opinion about it. Because regardless of what the literature may say, if they feel really strongly that the steroid might have a negative impact, I think it's really important to collaborate with them on this piece.
I completely agree with Marty, though. I have heard opinions from medical oncologists a little bit all over the board here.
Mm-hmm.
Some of them are fine with them. Some of them are fine with patients even on doses like daily, greater than 10 milligrams of prednisone. I mean, truly the 10 milligrams of prednisone is a very arbitrary cutoff. It's very arbitrary. It's just kind of considered and always been considered the kind of the immunosuppressive split. But truly, we don't know how much steroid might impact immunotherapy or not. We don't. So it really, I have some medical oncologists who are like, nope, we got to try to do it, nothing at all. And I have others who are, yep, nope, that's fine. We got to treat the patient, whatever works best.
Mm-hmm. Dr. Bott is also agreeing, discuss with the oncologist, and then if they're in agreement, try the short burst of steroids as well.
What about her age, Peter? I mean, I know that the dose of steroids is fairly arbitrary. I know there's also some literature out there that shows that once you get beyond maybe 7 milligrams of dexamethasone, you have increased risk of side effects from many of these steroids. And I'm seeing an elderly patient who's probably fairly frail. I might be hesitant to do something like 10 milligrams of dex every day and really worry about worsening her delirium or increased risk of side effects. I think I'd probably start with 4 or 6 a day.
Mm-hmm. Yeah, I would agree with that as well. I think Dr. Sharma mentioned the 4 milligrams as well in her recommendation too. So, yeah. So based off of the literature I presented, would you feel more comfortable being more aggressive with using steroids in these situations? Or would you still just be hesitant and really want to not press the medical oncologist if they said, no, I don't want to use them at all?
Hi, this is Patrice. I think as the experts in symptom management, we're, responsible for knowing the literature, and I don't know if I would consider it pressing them, but, let them know what we know about the literature on it, and that we're not worried about that, but we want to talk to them. And if they really still remain resistant, then that's fine. But I think it's an opportunity for education.
And I can, I think I'd feel more comfortable as well, but I also think based on the things that you've shared, I think I would be more apt to collaborate and reach out, because you never know how the medical oncologist is going to respond. And, you know, with consult etiquette and needing to collaborate and keep those lines of communications open, I think I'd probably just make sure they were okay with it first.
Mm-hmm.
Knowing that there's such a disparity between, you know, the range of how people respond to that, you know, the use of it. So
Yeah.
I agree. And this is Pooja. So if there are two reasons to use it, I think medical oncologists would be more open. So if you have COPD exacerbation, you need to treat that before you continue your treatments, or even, you know, give more pembrolizumab. So I feel like at that point, if there are two reasons, especially if there is an acute medical problem going on, which needs to be treated before we can go for more cancer treatments, I have seen them being more open for trying the treatments, and make sure that we first take care of those treatments and then go for cancer treatments, right?
I agree, Pooja. I think it warrants a discussion, and I would probably be, after hearing Peter's talk, be more inclined to, you know, discuss it with everybody. But yeah, ABCs, you need to protect the airway first.
I was going to say that too. Looks like Dr. Sharma has a comment.
Yeah, I just wanted to mention that what I've found helpful at times is that a lot of these patients who've had pain related to the cancer, and we are trying to use steroids for management of those symptoms, I'll look at what they've received in terms of, you know, sometimes just as a pre-medication for some of their systemic chemo, they've received high doses of steroids, like usually for chemo-induced nausea, vomiting. They're giving like 12 milligrams of dexamethasone is a common pre-medication that they've used. And you can even ask them that, hey, you know, when you were taking the dexamethasone previously, in the few days before your chemo, did your pain improve with that? So you may have some, you know, you could get some data prior to recommending steroids from that. Because sometimes patients will say, yeah, you know, when I was on the dexamethasone, I actually felt much better with my pain. So you could definitely consider that. If there is worsening of like a COPD patient who gets worse, you need to also consider whether this is, you know, some kind of a reaction to the immunotherapy. And generally the oncologist would hold off on the treatments while they're working that up, just to make sure that it's not like an immune mediated response to the treatments, you know, some kind of a pneumonitis or something else going on, which again, steroids would be used for those, you know, to manage those side effects as well. So.
All right. Well, from the literature I reviewed, here are the takeaways I had. Certainly don't hesitate to treat immune-mediated adverse effects, and I would argue palliative symptoms exactly as the group has just discussed. If they're having a medical issue and steroids is the primary treatment, you got to treat it. You can't continue with cancer treatment and things until that's acute issue is taken care of. Had to throw in what you guys hear over and over and over and over. Steroids for the shortest time at the lowest effective dose, of course. You know, that was in every article I reviewed. So had to throw it in there. But based off of the conclusions of all the literature I reviewed, they stated that really steroids themselves do not appear to significantly alter the anti-tumor immunity. That was one of the conclusions of multiple of these particular papers.
Great.
And anything else from folks today, or if not, then we'll just wrap up.
Peter, I just had a question that what is the shortest dose where you don't have to taper the steroids? Is there like a, 5 days or 7 days, or is there any?
No hard and fast rule, unfortunately. Really depends on the patient. At times, I would say patients that are a little bit older, a little bit more frail, tend to require tapers more often than younger, less comorbidity patients. The rule of thumb that I've seen over and over is if you're doing it for a week, I believe it's a week or less, and 60 milligram of prednisone equivalent or less, you usually don't need to taper. Gosh, I can't do this off the top of my head. I don't know how many 60 is in dex, but it's 5 of prednisone is equal to 0.75 of dex. So 12 times 0.75 would be 8. No. 9 milligrams of dex. Does that sound about right?
About that.
Somewhere around there. So if you're doing
Give or take,
9 of
yeah.
around 9 of dex daily for a week, probably still fine. I'm not needing to taper in the majority of patients. Now, that is not true in certain treatments. Immune-mediated adverse effects is one of those treatments where if you abruptly stop, they more often than not come right back. You have to taper for immune-mediated adverse effects. If you are involved in that treatment in any way, shape, or form, it is always recommended to taper. Usually you're doing 1 to 2 milligrams per kilogram of either prednisone or methylprednisolone, for those patients for treatment of immune-mediated adverse effects. And you continue that dose until the symptoms resolve. Then you start to taper, usually over anywhere from 3 to 4 weeks. And that's just the general, they tend to recur if you don't.
Well, great. Thank you, Peter. And thank you for joining us today. This was great. Have a great day, everybody.
Great. Thanks, everyone.